For the Akin procedure, which is usually necessary after correction of the first metatarsal, and then you have a hallux valgus interphalangeus, you can use the Akin osteotomy. It's a medial-based closing wedge osteotomy, which gives you a good correction potential, especially for the long tendons, the long flexor, long extensor. You can adjust where they run and they protect your correction. And also if the patients would like to have a good cosmetic result if you adjust the intermetatarsal hallux valgus interphalangeus. So before starting, we are going back to mark the joint. The first metatarsophalangeal joint is about that area. The IP joint is at that place, and between this there's a correction. Usually you can do it in the proximal third of the phalanx. Two reasons for this: the potential of correction is much higher if you are in their area than in this. In rare cases, you have a tilting in the IP joint. You can do in distal Akin, but usually it's a proximal Akin. The next point, you have much more cancellous bone in the proximal part, so the healing potential is also much higher than mid-shaft in this area. Before doing the cuts, I mark my position where I would like to do the osteotomy, go in with the burr and do an X-ray. This is a good place for me. I'm in the proximal third and I'm away from the joint. Also, I have place to bring in a screw in this direction. If I do the cut at that area, I can bring the screw like this, and I have enough space and I'm as far as proximal as possible. To do the Akin osteotomy, you have two different options of incision. I like to go from dorsomedial. There's some colleagues, they're doing a mid-shaft incision. The reason for me to do it in a dorsomedial way is I can easily cut the medial aspect a little bit more from the medial aspect than from the lateral. If you're going directly this direction medial, you're cutting the main area, the medial part, and also a little bit more from the lateral, the same amount. So you have to work a little bit like this. And for me, the handling is much easier if I come from this dorsomedial aspect. The burr which I use depends on the size of the bone. So we have a phalanx. So for this bone, the 2 millimeter and 30 millimeter length of the cutting area is fine for me. And also the Shannon helps you to work from inside the bone to outside in its cutting that area. I've marked my position under the X-ray. I know where I am, so I do a small incision. And now I'm going in with my burr and that area. Just to be sure, I take another X-ray. You have to have a look toward the joint. If you're tilting too much toward the joint, you're running inside the joint. So try to be perpendicular to the bone so you're avoiding any kind of joint damage. So what I do, I go in with it, and as soon as I'm in, I stop. I take my X-ray, and you see I'm too far proximal pointing. So I take it a little bit back, correct my position, and this is what I like. So just bring the burr in, take an X-ray, and then it's quite easy to take off the dorsal. And then as soon as you lose the contact to the bone, stop it. By this, you avoid damaging of the tendons. And the same thing, plunger. Tilting the burr. Now you can take an X-ray and have a look about the amount you have taken already. The lateral cortical is still stable. It happens that you cut the lateral cortical, but it's easier for you if you avoid. And then I'm tilting the metatarsal in the position I would like to have it, and just run the burr under correction position. And be sure that you have cut the medial cortical. So now I've cut the medial part of this, and you see it's closing already, but there's still some cortical bone on the medial. And if you don't do an X-ray, you try to go much more to lateral, but the problem is still medial. So go in and take off this obstacle. Now you can close it, and it's closed. So usually it's a medial problem. If you have not a good attachment of the bone, take an X-ray, control it, and then you can close it like this. Next step will be the fixation. Fixation is the same procedure as you know it from the open procedure. You can bring in a key wire. As soon as you have the key wire in, you can bring your screw and fix it. And the lateral cortical is intact, so one screw is definitely, in my view, enough for fixation. I start a little bit more plantar, and I take an X-ray if I'm on the right position, like here. And then you can point a little bit more proximal. And as soon as you have reached the osteotomy site, close it. And then you have your Akin osteotomy fixed with the key wire. Now you can drill the hole, bring in the screw, and fix it.